All right, great. So first of all, thank you for having me. I promise to not go over the timing, but I had a little bit of a technical difficulty getting my computer system and the office working. I'm really happy to talk at your Grand Rounds today about something that's very interesting to me and very exciting to talk about, but also kind of opens up the real truth behind how we deliver medicine and what kinds of things we need to be aware of and what we need to change. Okay, so we're going to talk a little bit about cultural competency. But I think before we talk about cultural competency and really what that means, we also have to identify the bigger question. So cultural competency in general, and we'll get to the definition in a little bit on other slides, but cultural competency really to me means that we're talking about how aware we are of the role of the individual's culture and everything surrounding their being in the way that they perceive medicine, in the way they receive medical care, and in the way that we deliver that medical care to them. So, the definition gets a little bit more specific as we go into this. So I like to always start when I talk about this from the direction of asking the question, when, if ever, is it appropriate to use race and ethnicity to guide medical decisions? Now, I think in this, we've sort of evolved into this environment in this world where we've really started wanting to pay attention to this and really how much of an impact this plays into our everyday roles, but more so as physicians, because we're dealing with just a wide variety of individuals of all backgrounds and races, ethnicities, and everything sort of in between. So we have to look at the role of race and ethnicity and in that culture in general. So that can include socioeconomic status, cultural values, things that they've grown up with, et cetera. But we have to identify and examine the role of race and ethnicity in things like the delivery of healthcare by physicians and healthcare workers. The role of race and ethnicity in the way that patients perceive the medical care they're given, because it's not all received the same way. And also its role in the way that patients are approached and treated by physicians in general. So we have to ask the question, should we even be considering race and ethnicity in our approach to patients? I mean, shouldn't we just be treating each patient individually, but as in the same manner, sort of as just a human being, right? Well, I think we have to remember that at no time has the health status of minority populations been equal or close to that of their Caucasian or white counterparts. So that's important. And so it kind of makes it seem obvious then at that point that, well, maybe we really aren't treating them as an equal playing field, and that maybe we really do need to be considering race and ethnicity, or maybe we're considering it too much. And so we'll get into the details of that. Also of point is that overall health has improved for Americans in general. We know that to be true, decade by decade. But there's an increased burden of morbidity and decreased life expectancy amongst certain races and ethnicities that has not changed. That's also something that we need to be aware of. So we have to ask, well, why is that happening? And should we be making a little bit more, paying more attention to that? And then classically, we think that the explanation of disparities among ethnic groups lies within the social and physical and economic environments from which they arise, right? So we always think, well, there's a disparity because, this is an individual that maybe lives in an environment where healthcare isn't accessible, or they live in a much poorer part of town. But I think what we realize is that it may actually be determined by a larger issue here: societal norms, values, how we socially stratify our patients. What's the political environment and economy right now? What is their accessibility to different economic opportunities? So I think it's incredibly important for us to look beyond and say, listen, there are things. If we were treating everybody as one equal playing field in our patient population, then don't you think some of these things would have changed? That everybody would have access to healthcare and everybody would have the same improvement of morbidity and improvement of life expectancy, for example. So we have to ask those questions and whether or not we really should be considering race and ethnicity to improve those platforms. So what are those factors that affect social healthcare delivery and health status of our patients? Well, we call them social determinants of health. And this has really become sort of a buzzword or buzz language now in healthcare and health management. Some of the determinants are general. So lack of health insurance. If you don't have health insurance, it's a determinant to you accessing healthcare. Socioeconomic status, lack of financial resources. People just can't get their hands on the finances to be able to afford healthcare. Location of services and patients. Look, if you live in a rural town or if you live in an inner city and there's just not more than one clinic available or not more than one doctor available, you're going to have that obstacle. You're not going to be able to access the healthcare. What about legal obstacles? Certainly, legal issues come into play when we talk about immigration and some of the barriers there. Structural barriers such as transportation, lots of wait time in offices where a patient only has 30 minutes for lunch. They go, they want a doctor's appointment, they go back. They have to go to their job. And if they're late to their job, they get fired. So there's these structural barriers for the patient that limit their access to healthcare. Language barriers, we know that all too well. Because we have such a varied and diverse population of different language speakers. And so we know that can sometimes be a barrier to healthcare. Lack of providers. Then what about the racial barriers? So when we talk about these are the general social determinants of healthcare, of health, I should say, and things that impede access to healthcare. But there are certain things that might be a little bit more specific in terms of a racial aspect of things and racial and ethnic healthcare disparities. So differences in geography. Okay, so we may say that there's a very large Hispanic population in this one part of the city. Well, that's all fine and good, except that there's no clinic there. So there's no way they can get to sort of their weekly health checks or their monthly health care that they might require. Lack of access to adequate healthcare coverage ties into that. Communication difficulties between patient and provider happen all the time. I mean, we experience that with language barriers. We also experience that when we talk about health literacy. There might be certain populations that live in certain parts of the city that may have decreased access to educational resources, let alone healthcare resources. So they've never quite gone past a 6th grade education. And now we're talking about someone who may not absolutely understand what the physician is trying to explain. And then that sort of tires the physician, and we sort of see this break in communication. Cultural barriers. Well, that's a really big one, right? Because a lot of times we'll make recommendations that we think will work across the board, except it doesn't work for the individual who already comes from a cultural background where modern day or conventional medicine isn't trusted, and what's trusted more is some of the more natural remedies, or what's kind of more comfortable to the patient might be something they've grown up with generations back. So we have to be aware of that. That doesn't need to be a barrier, but oftentimes it is considered something that might be just a limitation for the physician and the patient both. Provider stereotyping. We see this a lot more than we'd like to admit. There's a lot of stereotypes that carry over when the patient enters the office, whether it be the way that they look, the color of their skin, their age, their gender, their background. So these types of stereotypes definitely come up, and oftentimes it's the individual that's going in to treat the patient. But let's not forget that the individual sitting in that patient's chair may also have their own stereotype of the provider coming in, based on their own prior experiences. And then, of course, lack of access to providers. That goes along with, I think, the idea that certain ethnic groups may live in certain areas where healthcare isn't as accessible. And again, that plays into what I'm going to talk about here. And that is, you know, it may not just be that, well, you have this one population, this one area where you have a heavy population of Hispanic individuals living. It may not be that they feel only the most comfortable there, but it may be also that that's the most affordable place, because maybe there's a disparity in the income levels, or in their access to jobs, or in their ability to get a job because they're not a citizen, et cetera, et cetera. So there's so many roles that play into this beyond just the race and the ethnicity on the surface. Now, all of these are seemingly influenced by the race and ethnicity of the population, sort of that list that I just went over, but it's also based on that social context. And I'm going to reiterate a couple of times in this talk about the idea that maybe more African Americans and Hispanics may live in areas further from major healthcare facilities. We know that to be true on demographic data and studies. And this may reflect their socioeconomic status. It may reflect the disparity of wages that they're given. And we know, sadly, that's true. What about disparities in education? Again, if you have someone who's been educated only through middle school and another who has, you know, an associate's degree, or at least someone who graduated high school, their opportunities are different. Unfortunately, this can then also lead to the assumption of inferiority. And I say this, and some of the stuff that we're going to talk about today is kind of hard to hear, and it's kind of hard to identify within ourselves, but that's what is going to lead us to the talk about cultural competency and cultural humility, which is such a big deal now in medical education. But this is where it's stems from, the idea that maybe we all have an assumption that there is an inferiority or superiority, whether it be not of just race and ethnicity, but of understanding, of health literacy, of interest in their healthcare, of ability of access. I want to just point out that, you know, sociologic studies are always tough. Socioeconomic studies, they're oftentimes based on limited databases. Methodology has to be really strong to collect this kind of data. And for a long time, these conclusions that I'm bringing up to you were really speculative. And now we're trying to look for some very objective pieces of information. So the first step towards cultural humility or cultural competency, though we're changing the terminology, is to ask the question, how have social determinants of health, that list that I just went over, impacted my patient care interaction in my population? Now, again, everybody's population is different. Our patient population here at Valleywise is going to be very different than the patient population, say, in Paradise Valley in a private care setting. Private practice setting. So we have to identify that. That does not take away, though, social determinants of health. There are going to be individuals who are older, who don't have access to transportation, even, you know, in the populations outside of Valleywise. So we have to consider that in this whole global question we're asking. So when we ask this, let's talk about some observations that led to the question at hand. Well, if we talk about, and again, I'll go back, if we talk about some of the social determinants of health that have impacted my interaction, I'll say that the observations that have been made in a global sense are language barriers limit delivery of healthcare. Okay, language barrier is a social determinant of health. It can be a real obstacle that can limit the delivery of healthcare. How? Well, physicians may, and these are, by the way, I just want to say, these are observations that have come from survey studies, observational studies, interviews with physicians, interviews with patients. They've come up with really objective measures and objective data that can be followed as well. Okay, so this is not just, you know, a group of physicians got around a table and said, hey, listen, this is what I think. It might have started that way, but there's a lot of objectifying here too. All right, physicians may explain in less detail because of the language barrier. So the idea is that the patient won't understand quite what I'm saying because, you know what, I mean, they won't understand what I'm explaining because of the language barrier. And patients might actually feel that they would get better treatment if they did speak English. I mean, that's so hard for me to hear, and it's a shame, but in fact, that has been shown to be true. Also, just as a quick aside, I also want to challenge each of you in the audience. When I'm going through some of these, I want you to think about your patient interactions and really be true to yourself and think, does this happen to me? Have I actually found myself kind of explaining something in less detail because I figured they're not going to understand it? And again, it's really not to judge yourself, but it's to make yourself fully aware of what your barriers and your limitations have been. And this will then bring it around to the last set of slides that we have that will talk about cultural humility, because that's what we're practicing right now. Physicians may feel threatened by the constraints of time. I mean, don't we all have just an exam room, a waiting room full of patients that we need to see, and we know that we're getting hung up because not only is this patient complex and needs our help, but the patient also speaks Spanish and we're waiting for the interpreter, or there's a lot of misunderstanding because of that. Sure. And so it can really rush a physician through and make them feel like they're constrained for time. Physicians may feel their own limitations, their own inability to speak the language. I'm partially okay with Spanish. I pride myself on what I know and what I can understand and what I can speak. I really do. But I'm also very frustrated with my own limitations and the idea that I just want to kind of rush it along because I understand enough, but not enough. So I wrote MIHS here because when I gave this, we were not Valley-wise, but I want to point out that the slides have been updated. That was not the one. But we haven't, I point out here in red, the things that we've done at Valley-wise to try to improve that. How do we limit the barriers here so that we can provide adequate healthcare? Well, we have interpretation services. And yes, I agree, we could use a lot more interpreters. The ones we have are exceptional, and we have the phone system. And I just think that even offering that is something that our patients appreciate. And I appreciate because I can at least facilitate a visit that I know I'm going to get the details out of. As many of you know, as a rheumatologist, my world is about your history. And so I need to be able to dig really deep, and that helps me. What about the observation that has been made that perceptions of socioeconomic status often play a role in the equity of delivery of healthcare? Okay, I'm going to say that in another way, I'll paraphrase, right? That it has been observed that physicians and providers do take into consideration the socioeconomic status of an individual or their patient when delivering healthcare, and that sometimes it makes it a little less equal. Patients have been surveyed and they feel as if they feel that if they are perceived as coming from a lower socioeconomic class, they will receive less than optimal care. The individual who says, if I look poor, I'm going to be treated like a poor person. And that's an actual quote from some of these studies. I mean, it's kind of heartbreaking, isn't it? But the reality is that physicians have been surveyed, and there has been, some observational data that has suggested this. Physicians may perceive such patients as having ulterior motives, such as disability, like, oh, there she goes, she's in with chronic pain. She doesn't have insurance, and she's going to ask me to fill out a disability form, and she wants narcotics. I mean, I'm not saying anything that physicians have not thought to themselves if they're being honest. And if they haven't, I wish they would go out and teach the others, because this is definitely something that we have run into, and patients have felt as well. And that most certainly breaks any type of physician-patient relationship, and also the efficiency and success that we might have in providing good health care and providing health to these patients. Patients perceive physicians as identifying Blacks and Hispanics as poor, uneducated, and in one paper I read, as described as low breed. I mean, again, whether or not we believe, I truly put myself in a category of individuals that don't think like that. But, again, we have to dig deep and realize that maybe there have been times where we've also identified that. And again, for us as physicians, I mean, we can talk about this in a very social sense, right? In a very worldly sense. But let's take it one step further and say that as physicians, we're supposed to put that on a back burner. the patient wouldn't be able to afford a certain intervention, so why should I offer it in the first place, right? If they can't afford it, it's probably off the table. Well, listen, that may be something we need to take into consideration, but we need to relay it in a very different way. I also want to point out that sometimes it becomes very important to take these issues into consideration so that we can provide them at least the care that that we know we'll be able to offer them. Okay, so what I mean by that is this. Many private practices will not accept access as an insurance, so patients can't be seen there. We do, and we will gladly see these patients, right? Patients will sometimes feel, though, that if I go to Valleywise or if I go to a place because I have access and this private group didn't take me, I may not receive certain studies, certain workups, referrals because of my socioeconomic status. How have we challenged this? How have we decided that we at Valleywise are not going to let this continue, let that happen, right? We want to, so I use full disclosure in my clinic. I say, this is what I want to order. This is what I'm going to order, but this is what's more costly. So the decision is going to be yours in terms of what's prohibitive, what is not. I also will tell the patient, look, I absolutely need this test. We're going to have to work to figure out how we're going to get it. This could, this will make or break my treatment decisions. Or in an ideal world, if you were able to afford this, I would love for you to go get that echocardiogram, but this is purely a screening tool for your scleroderma. And I think it's okay if we have to wait for another year until you're able to get your finances in order. That's okay. We do have sliding scales. As you know, we have ways of being able to subsidize some of the studies as we need. And depending on the hospital systems around, wherever you go, whether it's here or elsewhere, certain schedules are already predetermined. So patients will actually be able to be put into a slot allocated for an access patient or a number of private patients. So, and why is that? It's not because it's a longer period of time that's allotted to the patient or less. It's just that way we have slots so that the patient who has access doesn't feel that they will never be able to get an appointment, that they have to take sort of second tier to the person who has a commercial insurance plan. And we've also, pre-COVID, we had gone to open access schedules. So patients, no matter what their insurance status, could call up and say, hey, I need to be seen within the next 5 days. They would be brought in. So we're trying to eliminate this negative stigma of a socioeconomic status playing a role here in the equity of delivery of healthcare. And we're trying to sort of say, look, even playing field, but when you're in the office, we can talk about what you're capable of affording maybe, or what's prohibitive, costly at this time. Next observation, that ethnic minorities get less respect. They get less direct eye contact or direct exposure, less time spent at the visit, less time that the staff will assist the patient, longer wait times for return calls, like all of the above, right? So one would argue that it doesn't matter what your background is, that this all happens at every doctor's office. But that said, the observation had to do with race and ethnicity. How have we countered that? Because this happens, right? This happens all the time. I've been a patient, my family members have been patients, and this happens. And I'd like to believe that it's not just the color of my skin, but it's in fact just a global defect of the healthcare system, and people are busier and we're just so inundated. But we've at Valleywise have decided to change this over, right? With things like diversity of the staff. Increasing that is exceedingly important because it allows for patient comfort, it allows for patient interactions to be better, more positive, and maybe an understanding and a trust. We do have a bilingual staff, and I think that we, across the board, need to have that increasingly nationwide. Standardized patient satisfaction surveys go out all the time, and I would like to say I'm very proud of my patient satisfaction, and I'm really grateful because I work hard at that, but my heart rate still does go up when I get that in my inbox because I'm always worried and all of that. But and then the education of providers, things like this, these opportunities to be able to have a conversation together and teach each other what we need to overcome so that we can provide some really good, solid care to our patients. And then other issues, things like transportation, look, we see patients if they're late, and we might say to them, hey, listen, we're going to have to fit you at the very end, but we'll see you. And again, that's on a case-by-case basis. I mean, certainly if things don't work out, they don't work out. And there are going to be times where, I'll say, I'm sorry. I wish you had shown up on time. We're not going to be able to see you, but we'll reschedule you and we'll make it work. We have assistance programs for medications. I prescribe a lot of biologics, a lot of medications that just require a lot of prior authorizations, but we also have assistance because they're expensive. And patients just are not going to be able to afford thousands and thousands of dollars for the medication. So we have great assistance programs through foundations that will provide assistance for them. And then, of course, our wonderful outreach clinics spread across the valley. So access to healthcare is less of an issue because we have so many valley-wise family health centers that patients can go to. So then we have to ask the question, when is race and ethnicity important in making a medical decision? Because I just got done basically pulverizing the medical profession, right? And saying that we all don't think about these things and we're all stereotyping and we're all coming in with implicit bias. Look, that's not the case. It isn't. But we also have to, while we're working on that piece of it, we also want to talk about when race and ethnicity can be important in making medical decisions. Look, assuming all factors are equal, right? So we take socioeconomic status, equal that playing field. We take access to healthcare, insurance status. We put that all on an actual even playing field. There are still other things that race and ethnicity will play a role in. For example, presence of disease, occurrence of disease. Race and ethnicity sometimes, more often than we think, right, can dictate whether or not an individual is going to get a particular disease. The actual diagnosis is definitely affected by race and ethnicity in some cases. Certain diseases are more prevalent in certain ethnic populations. The burden on the body. Certain people, an individual who's Hispanic and an individual who is of Scandinavian descent, okay, or a Caucasian male, a female, they will have different manifestations of their lupus, and the burden on the body may be more in the Hispanic woman. Severity of disease, course of disease. What about response to treatment? You might find that African-American women are more responsive to a certain medication for their lupus as compared to their Caucasian counterpart. And then prognosis of disease and outcome. Now, I don't have to reiterate this. You all have seen this be the case when you've seen certain diseases, whether it be stroke or rheumatoid arthritis, right? So this is the other side. It may stand to be true that if we are aware of all of the above factors impact on race and of race on disease, right, then a physician's clinical approach may vary based on race and ethnicity of the patient. And I am very upfront with my patients about that. I will let them know that it is incredibly important that we start this medicine early on you because of your Hispanic heritage, because of the fact that you have a family member or 3 family members that have lupus, which is not inconceivable, we may want to approach you a little differently. The goal of the physician should be to approach race as a biological category rather than a social one. I'll say it again. The goal of a physician should be to approach race as a biological category, not as a social construct. When we are, and I should continue that, when we are managing their treatment, okay? Very important. Variations in genotypic characteristics do exist. We know that there are differences in the picture and the genotype and phenotype, but the genotype of that individual with lupus, for example, right? So focus on race as a social construct in medical decision-making may not achieve that goal of managing the disease properly. So we may want to say, look, I'm focusing on this because you have a different HLA haplotype. I just know you do because because in studies, Hispanic individuals have this haplotype, which means it carries this risk of this particular complication, lupus nephritis, for example. And so if that's the case, then I'm going to have to consider that race as a part of your treatment. Or I know that you're going to respond better to Rituxan than your African-American counterpart or your Caucasian counterpart. So looking at it that way, as opposed to you're an Hispanic individual who maybe doesn't want to get healthcare because you believe very strongly against conventional medicine, that's not going to work. And we're never going to achieve our goal of that. And it's incredibly important that we identify where our limitations are there. You all know about this. These are always board questions, but diseases that affect specific populations. Well, it's listed right here, but we know. We think about celiac disease, for example, in patients of Irish descent. You talk about patients who are of Crohn's disease. Well, we're talking about more in the Jewish population, Ashkenazi Jews to be exact. Same with Tay-Sachs. What about SLE? I've been talking about that. Hispanics and African Americans are more prone to not only development of the disease and occurrence of the disease, but most definitely the more complicated manifestations. So it stands to be fact. The more that is learned about human genetics, the more apparent it will be that ethnic origins can provide valuable information and insight for better diagnosis and management. We have to scientifically look at it and take that into consideration. And we'll be able to do that more once we talk about more customized medicine and really going deeper into the genetic typing of patients in general. Transplantation rates, for example, have varying success rates among different ethnic groups. Okay, there's got to be a reason for that. Is it because there are immunogenetic differences amongst ethnic groups that directly impact rates of rejection? It's got to be more than they just couldn't get a transplant, or that the Caucasian individual was given the transplant before the African American individual. There's got to be something more than that as well. Survival rates of renal transplant in Blacks has been shown to be much lower than in any other ethnic group. There's a reason for that, right? Diabetes among Native Americans, again, we all know this to be so true, and we know that amongst our own population of Arizona Pima Indians. So again, just something to be aware of when we consider race and ethnicity in disease manifestations. And then the next point, of course, to be made is accommodating the patient versus patient responsibility for their own health. I just said this to Colin, my medical student, if you're listening. We just talked about this with a patient today, and the idea that we have to identify how much of this is our responsibility as their physician, and how much do we expect patients to take responsibility for their own health. It's a real it's a real gray zone until you don't make it a gray zone. And it takes communication with your patient, and also identifying in your own mind as a physician, what is it that you're willing to kind of accept and do. So it's not unusual that patients will feel concern and fear regarding their diagnosis and management plan. I mean, I don't need to say that over again. We all know that to be true. If you've been a patient on your own, you know that. Many will decide, though, through that fear, they'll decide not to follow through with the recommendations of the doctor. Why? Because I'm afraid of the treatment, I'm afraid of the management, or I didn't feel like I got enough of an explanation, so I'm not going to do it. Many may not follow up for that because of that fear or that concern. Maybe patients feel that their doctor doesn't really understand them and they don't relate to what's going on, right? Kind of the reason why I'm telling all of my patients that I got my COVID vaccine, because I want them to know that if I'm recommending it for my patients, I'm going to take it myself. So a lot of times patients may not feel that connection, and they may feel that they're being talked down to or they're being dismissed. And I want to be clear, I have had a patient who thought that she was being dismissed completely when I told her that she needed to take responsibility and take the medications that I had prescribed to her. And it happened time and time and time again, to the point where I wasn't making any headway. But I needed to be very clear. I was not trying to undermine her or her understanding of her disease, but I wanted to make sure that she could get the best out of what I was offering for her. So, methods to improve the compliance here. How do we make sure that patients understand that they can take responsibility, that they too are empowered with their health? How do we do that? Well, we can make sure that they understand what we're telling them. And if it means that we have to use interpretation services, even if they say, no, my English is good, it is not to offend them, but it's to say, listen, maybe I'll just have somebody on standby so that if you do have questions for me, that maybe they can better explain it to me. That's kind of an approach I take, so that there's nothing lost in translation. Diagrams and models. I really love drawing things out. You know, I don't get into a lot of detail with the immune system, but let's face it, the immune system is something that's evasive to physicians in general, you know, all the best ones. So sometimes it's nice to describe what I'm talking about, even if it's a body part or if it's, you know, like what an antibody and an antigen is. And some people will ask, so it's always a pleasure to try to do it that way. I always have patients repeat their understanding. If I'm getting a sense, not everybody, but if I'm getting a sense that maybe they didn't quite understand it, I'll have them repeat their understanding so that we know that moving forward, they have the tools to try to help themselves. And then of course, as we always should do, end with, now what questions do you have for me? And we can help tease out those questions as well, but give them that opportunity and give them the good explanation. And now, the theme and what we were sort of leading up to with all of this is really what the title of this talk was in the first place, cultural competency. But, you know, again, I want to just reiterate, it's such a multidimensional topic. So I think we needed to identify, and then get to what this is. So cultural competency, and if we were in a conference room and we were all together, I would have you all raise your hands and take account of who's heard of cultural competency as a teaching, as a course, or as something that needs to be addressed from medical training onward. Cultural competency is considered a finite understanding of a set construct of knowledge of other cultures in and out or out of healthcare, right? So I'm culturally competent. I know that this is what happens in the Hispanic culture. I know what happens in the Native population. I know it. So, but the problem is that can often lead to paradoxical stereotyping. So if I say, oh yeah, no, I know that the Native American population believes in spirits, for example, or in those who have passed and they provide and I go on and on about what I understand. Well, right there, I may, first of all, be completely misunderstanding. I may not know the whole history. And then I may be assuming that, well, that's why they don't want to try conventional medicine, right? And I'm also stereotyping. I'm completely stereotyping a situation where I may not understand, well, that's in this one tribe. It's not considered an issue in this tribe. And maybe I'm missing the boat altogether. So there's a lot of limitations when we talk about cultural competency. We've changed the language to incorporate something called cultural humility. This actually incorporates a lifelong commitment to understanding, as well as self-critiquing and self-evaluation to minimize the physician-patient power imbalance, okay? So we'll tease through that a little bit. That's why when we started this, I wanted to have you try to understand and put yourself in the position of those examples that I was giving. You know, have you been in those situations as the physician? Have you considered that, you know, treatment of patients in a different way based on these factors? So what cultural humility does is it allows for you, it expects us to try to dig a little deeper and critique ourselves, evaluate ourselves to understand what are my limitations first, so that when I go into the patient's room, I'm not exerting this power struggle, this power balance to sort of say, well, here I am. I already know about you and your Hispanics and your cultures. And so this is what, nobody does that. But trust me when I say it seeds through and patients can pick up on that. And it prevents us from being able to provide really open-minded care. And by open-minded, I also mean just in terms of the medications we choose, right? There's a lot of filtering through and trickling down here. The goal is with cultural humility is to develop a mutually beneficial, benefits both the physician so we can do our job and the patient so that they can get better. And also it's to develop a non-paternalistic clinical partnership with the patient. Okay, this is not I'm lecturing you and you're receiving the information, but also to to enhance an advocacy partnership. I want to advocate for my patient just as much as the patient needs to advocate for themselves. It also allows for partnership with communities on behalf of these individuals and these defined populations. There was an opportunity to set up a pediatric lupus clinic with our pediatric departments here, so that we could identify a very heavy population of children, Hispanic children with SLE, because it's a thing and it happens. So what a wonderful opportunity for us to be able to develop a partnership with this group of individuals that need us the most, but we have to be able to identify, though, where the limitations are. Where are the holes that we can sort of go in and fill and help in a very non-paternalistic and an advocacy way. The Institute of Medicine defines optimal primary care, okay, as this, including an understanding of the cultural, nutritional, and that may mean physically nutritional or emotionally or mentally nutritional as well, and belief systems of patients and communities that may assist or hinder healthcare delivery. We have to understand what are the limitations and what are the benefits, what are the things that we can provide to improve healthcare delivery. Medical education needs to focus on this and measure those outcomes. So this is really where this all started. Now you start to see these medical, I mean, we may have had back in the 90s when I was in medical school, you know, we had some, you know, we had a course here, a course there, we had medical ethics, and this was all kind of lumped into that. Right? Nowadays, we're not seeing that. And a lot of medical institutions are incorporating cultural humility into their curriculum for 4 years as coursework, as field work, as clinical work. It's important to be able to start early because this is where the formative years, right, of how we deliver healthcare come. We're not talking about nature versus nurture and what you grew up with. We're talking about how we address the individual that is sitting in our office and is going to be a part, the sole part of the work that we are studying to do. The Pew Health Professions Commission has been asking now for cultural sensitivity, cultural humility coursework to be a part of all medical education. And this has been ongoing for several years now. We want to, in doing this and in providing cultural humility training, we have to do a couple of things. And people on the side of med ed, medical education really have to, they're putting a lot of emphasis on this and trying to do certain things to avoid the pitfall of teaching it. So teaching cultural awareness, right, as a finite body of information. Like, you know, going in and saying, okay, Indian people from India practice Ayurvedic medicine. They believe in this. They like this. They, you know, I mean, I'm sounding very stereotypical. It wouldn't be presented that way, but the idea that you associate a certain group or a certain cultural background with certain types of medicine or certain approaches to medicine, you can't teach it that way. Because, by the way, let me be clear, it is incredibly important to remind our learners that people who are of an Asian background may have a very strong affinity and understanding of herbal medicine. And people from the South Asian subcontinent might say, you know what? Ayurvedic medicine is an incredibly important part of our healthcare. So it is important to understand and really learn that. But we got to avoid the pitfall of teaching it as something that is so finite. We need to also be able to assess these outcomes with quantitative assessments. We need to be able to test our students and say, all right, you guys know that this is important in this cultural capacity, but how are we, how well are you understanding it? What are the boundaries that you're sort of not learning beyond? It's best to define it not as a discrete endpoint, but rather as a commitment and an active engagement that students would enter into with patients, communities, colleagues, themselves. That's how we want to identify cultural humility. And that's really what medical schools are doing. Medical schools and sometimes residency programs is a little tough. You're doing it now in this form, which is fantastic, but doing it over a longitudinal course of 3-4 years is really how it kind of just becomes a part of who you are, so that when you're out there, as an attending or even as a resident, you're ready and armed with an ability to ask the right questions and get the right answers. It requires humility. None of us wants to think deep within ourselves and say, yeah, this is what I've got going on. This is how I approach my patients. This is my implicit bias. Because it doesn't feel good, right? We're all in medicine to help people. That's pretty much why most of us went into this in the first place. And so, it seems so counterintuitive to think, well, I wouldn't feel that way about somebody because that would be harmful in a lot of ways. But in fact, it requires humility to ask for our own self-reflection, for self-critiquing as lifelong learners and reflective practitioners. And I can tell you, honestly, it's something I work very hard on. I think sometimes doing talks like this for the past several years that I've been doing them, it really reminds me, it's sort of a shock. And I'm much more aware in a patient's room when I'm doing it. Now, notice I said when I'm doing it, because it's not a matter of, oh, I never do it now. No, I do it. And I know I'd love to soon become more if I'm doing it, and then I never do it at all. But we have to be aware of that. It is the understanding of cultural differences in healthcare practices. And that understanding is so important in the prevention of misdiagnosis or drawing of conclusions. I want to be very, very clear about that. We may have individuals that are culturally stereotyped as being very resistant to medications, for example, or have a lower pain threshold. Like, they just, their whole cultural understanding of pain is, well, I deal with it. It's nobody, complains. And then all of a sudden we've missed the diagnosis because all we've said is, oh, she just has a very high pain threshold. What we're missing is the fact that there's actually something brewing underneath this, or vice versa. We can call something chronic pain and it wasn't chronic pain at all, because of the fact that we have this understanding of cultural differences that we're not identifying as finite and stereotypical. We have to beware of false security in our understanding of above. We can walk in, I've done it. I've walked in and assumed that my Indian patient sitting in front of me, I got this. I'm Indian. I know exactly what she's going through. I know that she probably tried X, Y, and Z, and that, well, I'm secure. Now all of a sudden I feel secure. I feel secure in my diagnosis of it. Oh yeah, the turmeric helped. It's probably osteoarthritis. All the while, not even thinking about asking beyond that and asking about some other symptoms or other things that she may have done that haven't worked at all. And now it's time to intervene. We have to make sure that we challenge our false sense of security that stereotyping brings. And if we don't identify that, we're never, it's like vasculitis. Any of you who have rotated with me know, I always say, you got to think of vasculitis or you'll miss it. So put it on your differential somewhere in there. It's the same thing here, right? If we don't identify that we are stereotyping in some way, shape, or form, or if we find ourselves saying, oh yeah, this is, she's of this background, so this is probably the case it is. If we find ourselves going to that thought process really easily, just stop for a second, pause, ask yourself, is that legitimate? Is that accurate in this particular case? Or am I maybe jumping the gun a little bit there? We have to be able to say, we don't know, right? We really stink at that as physicians, don't we? But we have to be able to say, I don't know the answer to that. And I don't, but I will find out the answer to that. There's a humility that comes with that. That is humility, actually. And we have to be able to be able to do that readily. And even if we don't know, what we do want to do is be able to change our attitudes towards diverse patient populations. If there is an individual, maybe an African-American individual who has a complaint or who has something going on, and we don't understand that that's something that's very true to them or their growth or the family dynamics that they came from, we're never going to understand how to actually better treat them. And that's incredibly important. It's something that can be very hindering. So we need to be focused on that. And then, cultural humility and not being aware of that or needing to be more aware of that, it's reflected in the prescription of clinical resources, right? So think about this, right? How we prescribe things, how we give patients prescriptions, or what we recommend in terms of services and life-saving procedures. Believe it or not, this can sometimes be based on the race and ethnicity of patients. Study in a particular university showed that Latinos were half as likely to receive analgesia for painful long bone fractures than white individuals when controlled for insurance status and linguistic capability. So everybody spoke English and everybody had insurance, and yet what they found was that these individuals that were Latino or of background were half as likely to receive pain control to the extent that would help them than the Caucasian counterparts. Now, when they were followed up, physicians said, well, we didn't perceive differences in pain between the two groups. And you have to ask the question, well, what was the reason then? And again, we'd like to believe that it isn't just because of their background, their ethnicity, but in fact, could it have been that there was a language barrier? Was it an understanding barrier? Was there an issue of health literacy? And if there was, did the physician take the extra step to try to explain a little bit more that this was not going to help your pain, et cetera? There's a lot there, and there's a lot that needs to be dug out. And sometimes it's just a really frank breach, and it needs to be addressed. African-American individuals in one study were twice as likely to go blind with glaucoma and other chronically progressive eye diseases, were half as likely to receive sight-saving procedures. We have to ask why. And while we're asking that why don't we look into ourselves and say, well, what would I have done in that situation? What do I identify as a limitation? We have to find a way to confront our own implicit bias and our own sense of racism and classism and phobias. I mean, we need to identify that. Our patients will have to do the same, right? Our patients need to give us a chance if they're not used to having, a physician that looks like us or talks like us or has an approach to medicine like us. But we are the ones that are providing that care. And so if we have to, cultural humility training or teaching, I should say, gives us a way to confront our own biases before we walk in the door. We have to focus a little bit more on patient-focused interviewing and care. And I know medical schools are really trying to address that, where physicians in general often ask 90% of the questions. We steer away from patient-directed questioning. So we ideally should be asking the questions based on what the patient is wanting to address and what the patient's symptoms are. So I know it seems like when we go in and we take a history on a patient, that of course we're focusing on the patient, right? I mean, we're focusing on what their chief complaint was. But then if you notice, just take notice of this one time. We find ourselves veering down the path of what our differential is and what we think is going on. What we might want to do is sort of stop and say, okay, well, wait a minute, I'm going to stop here for a second. Ask me questions, because maybe I'll direct the visit in a little bit more of a direction that's more focused on what your concerns are. And that's really helpful as a subspecialist too, because it gives my referring provider the actual answer that they really wanted. Studies have shown that certain ethnic groups wanted as much info about their care as others. It's not like they came in and they said, yeah, I'm a little less interested in my health anyway, just give me a medication. It's not really the case. But they receive less. Why? Because it goes back to our implicit bias of certain ethnic groups, certain language barriers, certain socioeconomic statuses, et cetera. Again, something we need to identify. Patient-focused interviewing, really important because it's less authoritative, it's less controlling. The patient will feel that. It tells the patient that I value your medical and non-medical opinion and agenda and perspective. I appreciate that to you, green smoothies are everything, but how can we intervene with a medication that we know will help prevent further progression? So those will help you feel good, and my medicine might actually help you with this. The patient may be more willing to open up, may feel less threatened, and it becomes less focused on the mastery of each cultural system, right? And it's more just based on the pathway and the patient themselves, right? This is important because now all of a sudden, I'm not assuming that herbal medicine is so important in this Chinese individual's healthcare. Well, maybe it isn't to this person, but maybe it is to somebody else. In this case, I'm just focusing on the patient, letting them direct me and saying, doctor, I wanted to just let you know that, herbal medicine is incredibly important in my healthcare. How can we put that together? This is an ideal case scenario, but the more we focus on patient-focused interviewing, I think the more we'll be able to actually veer less towards our biases and more towards what the patient actually needs. And then the last slide is really talking about consistency when dealing with our community and within the institution as a whole. If we can really focus in and hone in on what our obstacles and our own cultural implicit biases are, and really focus in on cultural humility, even versus cultural competency, I think we're better off for it. And our patients, in the end, will be benefited from this, not only from their health care, but health outcomes, their follow-ups, their compliance, as we call it. That's a whole other discussion, and really healthcare in general. And that's really where this comes into play. So stay tuned. There's more and more of this coming to light. We're learning more from an objective piece, and we're instituting much more of this in our medical education. So any questions at all? And if everybody was unmuted, I'm sure you would all laugh. I'm loving Grandpa. It's not that he found his way to Valleywise. So that's it. Do I have any questions before I wrap up? You can just unmute if there's any questions. And I'm happy to, engage in more discussion about this. I'm hoping that I'll have more opportunities to talk to you about some more focused lectures and things like that. But there's just some really cool data out there that I'd love to share at any time we can. So thank you so much for this opportunity. I really appreciate it. And I'm around if anyone has questions, okay?
Thank you, Dr. Chhaya.
Of course, Karen. I'm happy to talk with you all. Let me know if there's any questions. You can send people my way, okay?
Will do.
All right. Take care.